Hello, I am Raymond Kwong, a clinical cardiologist and the director of cardiac MRI at the Brigham Women's Hospital. I'm a professor of medicine at Harvard Medical School. I'm happy to be with you today to talk about the use of Gatavist, also known by its generic name Gatobutrol. Gatavist is the first and only gadolinium-based contrast agent, GBCA, indicated for use with magnetic resonance imaging to assess stress and rest myocardial perfusion and late gadolinium enhancement in adult patients with known or suspected coronary artery disease. Today, I'm going to show you some examples of cases of how I have used Gatavist to aid in imaging our patients. Please note that I am being compensated by Bayer to support this presentation.
It is important to know that intrathecal administration of GBCAs can cause serious reactions, including death. Gatavist is not approved for intrathecal use. Additionally, GBCAs increase the risk for NSF among patients with impaired elimination of the drugs. Avoid use in these patients. The risk of NSF appears highest among patients with chronic, severe kidney disease or acute kidney injury. Screen patients for conditions that may reduce renal function. For patients at highest risk, do not exceed the recommended dose.
I will demonstrate the cardiac MRI methods by showing a case from a 63-year-old gentleman with a history of multiple coronary risk factors. So the current MRI techniques has high resolution. What you're seeing is on the left are the stress perfusion imaging, and the middle column are the rest perfusion imaging, and on the right upper panel is the late enhancement matched by the same cut of cine imaging on the right lower corner. Note that the stress and rest perfusion imaging has high resolution to about 1.4 millimeters in plane, and a blood flow map is generated from the respective stress and rest imaging in the color panel below. These patients undergo the cardiac MRI perfusion imaging without any need for any breath holding or post-processing because the blood flow maps are generated automatically. This gentleman had a prior history of CTA recently and was noted to have moderate stenosis and was treated medically. He now came back with troponin elevation and recurrent chest pain. And note that the incremental additional information you can learn from the cardiac MRI demonstrating markedly reduced blood flow in the left anterior descending territory during stress, which is different from the low blood flow at rest. You can see a reversal of blood flow in the stress and rest images. Before we move on to the next cases, let's review details on Gatavist clinical trials. Gatavist is proven in clinical trials for cardiac MRI. Bayer conducted two multi-center open-label phase 3 studies to evaluate Gatavist enhanced cardiac MRI for the detection of coronary artery disease in adult patients with known or suspected coronary artery disease. The patient population was broad and enrolled patients with known or suspected coronary artery disease of any risk level based on signs and symptoms. Patients were excluded from the study if they had a history of coronary artery bypass grafting, or if it was known in advance that they were unable to hold the breath, or had atrial fibrillation or other arrhythmia likely to prevent electrocardiogram-gated cardiac MRI. Patients underwent Gatavist enhanced myocardial perfusion, including stress and rest imaging, and late gadolinium enhancement imaging within one session to ensure time-optimized examination, and a single standard dose of Gatavist at 0.1 milliliter per kg of body weight was used, divided into two separate equal injections for rest and stress perfusion imaging. The high concentration and relaxivity of Gatavist enable image enhancement with a single divided dose of contrast. The co-primary endpoints for these studies were sensitivity and specificity of Gadavis enhanced cardiac MRI for the detection of coronary artery disease in adult patients with known or suspected coronary artery disease. Quantitative coronary angiography was the standard of reference. A total of 764 patients were evaluated for efficacy and 904 patients for safety across these two global multi-center trials. This slide shows the high diagnostic efficacy that was demonstrated with Gadavis enhanced cardiac MRI across the two pivotal trials. For each study, images were read by 3 independent readers. Reader detection of coronary artery disease depended on visually detecting defective perfusion or scar on Gadavis cardiac MRI, including stressed rest and LGE imaging. Quantitative coronary angiography, or QCA, was used to measure intraluminal narrowing and served as the standard of reference. The left ventricular myocardium was divided into 6 regions. Interpretations were provided per region for cardiac MRI, reporting presence or absence of perfusion defect and or LGE, while QCA results showing presence or absence of stenosis of more than or equal to 50% or greater than or equal to 70% were provided per artery. These tables show the sensitivity, which is the detection of disease when stenosis was greater than or equal to 50% or greater than or equal to 70%, and specificity, which is the exclusion of disease when stenosis was less than 50% or less than 70% across 3 independent blind readers evaluating cardiac MRI images for each of the 2 pivotal trials.
Gadavis is contraindicated in patients with history of severe hypersensitivity reactions to Gadavis. Anaphylactic and other hypersensitivity reactions with cardiovascular, respiratory, or cutaneous manifestation ranging from mild to severe have occurred. Before Gadavis administration, assess all patients for any history of a reaction to contrast media, bronchial asthma, and/or allergic disorders. Acute respiratory distress syndrome has been reported with Gadavis. For patients demonstrating respiratory distress after administration, assess oxygen requirement and monitor for worsening.
Another case is a 66-year-old female with long-standing uncontrolled hypertension, and she presented with atypical chest discomfort. What I'm showing here is the stress perfusion imaging. In this case, is displayed vertically. The apical perfusion is demonstrated in short axis on the top panel, matched by the stress myocardial blood flow pictures as generated on the right here. The mid short axis perfusion is on the middle panel, and the corresponding myocardial blood flow imaging during stress is demonstrated on the right side. And the bottom panel demonstrates the short axis basal cut of the short axis perfusion during stress, and it's matched by the blood flow pictures on the right side. And as shown here, there is a perfusion defect, which is quite a bit easier to see on the map, demonstrating a concentric subendocardial perfusion defect that exists at the base, but also mid, but also involving the apical subendocardial segments, and is not matching the distribution of a typical coronary epicardial coronary pattern because it's so diffuse and concentric. At rest, after rest perfusion was acquired after vasodilatation was given and reversed with aminophylline. In this case, we gave it with regadenoson. and the rest blood flow is normal. And with this sort of picture, we can conclude that this is not a epicardial coronary stenosis type picture. Also because we now can have the blood flow values as demonstrated in the 16-segment model. On the left are the stress perfusion numbers and the right are the rest perfusion numbers. You can calculate the global myocardial blood flow values. As demonstrated here, the myocardial blood flow reserve is calculated by the stress myocardial blood flow of 1.61 divided by the rest myocardial blood flow value of 0.97, yielding 1.7 of myocardial perfusion reserve, which is reduced. In general, we use myocardial perfusion reserve of less than 2 being abnormal. We can also calculate the endocardial to epicardial blood flow ratio. It should be greater than 1, but in this patient's case, it was less than 1. These findings in combination suggest that there is a uniform pattern of hypoperfusion at the endocardial level, suggesting that there is evidence of microvascular coronary disease. With the high resolution of cardiac MRI, one can achieve quantitative evidence, such as the case that I am showing you here. The next case is the 48-year-old man with long-standing hypertension, similar to the last case. He presented with palpitations, but in his case, he actually had a Holter monitor performed and was noted to have several episodes of non-sustained ventricular tachycardia on monitor. Similar to the last case, I displayed them here in apical short axis, mid short axis, and basal short axis fashion, matched by the quantitative blood flow maps on the right. Here you can easily pick out that there is a perfusion defect in the lateral wall involving the lateral wall, but also the basal lateral wall, but also the basal infralateral wall as well. It involves the mid level and also the basal level in the in this area that is hypoperfused compared to the rest. But the map demonstrated more information. Beyond the dense perfusion defect during stress, there's also hypoperfusion in the rest of the myocardium that is of lesser severity. And when you look at the rest perfusion that was acquired at about 10 minutes later, you can see that rest perfusion has returned back to the low resting blood flow state. When we calculate the global myocardial perfusion reserve, it was actually globally it was normal, but the endocardial epicardial ratio was less than 1. In this case is different from the last case because there's clear evidence of epicardial stenosis related ischemia in the lateral wall. You can see that's dense perfusion defect that is reversible. There is hyperemia. He also has some degree of endocardial epicardial flow reduction. He also has evidence of microvascular coronary artery disease as well, in addition to his lateral ischemia. With these concerning findings of the lateral wall, he was sent to the cath lab and was noted to have a tight OM branch of the circumflex artery being tightly stenotic, explaining the lateral wall hypoperfusion.
Gadolinium is retained for months or years in several organs. Linear GBCAs cause more retention than macrocyclic GBCAs. Consequences of gadolinium retention in the brain have not been established, but they have been established in the skin and other organs in patients with impaired renal function. Certain patients may be at higher risk. Consider the retention characteristics of the GBCA and minimize repetitive GBCA studies when possible. In patients with chronic renal impairment, acute kidney injury, sometimes requiring dialysis, has been observed with GBCAs. Do not exceed the recommended dose as this may increase risk. Extravasation into tissues during Gadavist administration may occur and result in moderate irritation. Ensure catheter and venous patency before injection. The most frequent adverse reactions associated with Gadavist in clinical studies were headache, nausea, and dizziness.
Thank you for reviewing these case studies with me today. I hope you find it useful to see how we use Gadavis imaging to assess stress, rest, CMR myocardial perfusion, and leg gadolinium enhancement in adult patients who present with known or suspected coronary artery disease.